It's great to have you here. This is a joint effort from the Office for Faculty Affairs and Human Resources and the Office for Faculty Development and Diversity. We've got a great crowd. I want to introduce our presenter, Dr. Aviad Haramati, who goes by Adi. He is a professor of integrative physiology in the departments of biochemistry, molecular and cellular biology, and medicine, nephrology, director of the Center for Innovation and Leadership in Education, known as Centilli, and co-director of the CAM graduate program at Georgetown University Medical Center. So you can see he wears a lot of different hats. He received a PhD in physiology from the University of Cincinnati and came to Georgetown after 5 years at the Mayo Clinic. His research interests addressed renal and electrolyte homeostasis, but now he focuses his work on medical education and rethinking how health professionals are trained. He has taught physiology for over 35 years and has been recognized with multiple awards, including the Arthur C. Guyton Teacher of the Year Award by the American Physiological Society, the Alpha Omega Alpha Robert J. Glazer Distinguished Teaching Award from the Association of American Medical Colleges, the Master Scholar Award from the International Association of Medical Science Educators, also known as IAMC, and named Distinguished Educator by the GUMC Teaching Academy for Health Sciences. So his accomplishments have been well recognized. Dr. Haramati seeks to improve medical education across the globe, especially with regard to the intersection of science, mind-body medicine, and professionalism. He has chaired a number of international conferences, including the recent 2017 Centilli Conference on Strategies to Promote Resilience, Empathy, and Well-Being in the Health Professions, an international forum held in Washington, D.C., October 22nd through 25th of this year. Dr. Haramati has been a visiting professor at over 80 medical schools worldwide. And if you ever have a chance to talk with him, you'll hear about his travels around the world and his presentations in many different countries. So it's my pleasure to introduce Dr. Adi Haramati, who's going to help us learn to develop resilience and be less stressed.
That was a long introduction that only my mother actually believes all that stuff. So I've been invited to speak about resilience and stress and what are we going to do about it. And it's a topic that's actually on everybody's mind. When I say everybody, faculty, staff, students, academic societies, you. Otherwise you wouldn't be here, I think. Just out of curiosity, before I begin this, how many of you are staff members? Wow, the majority. That's actually a first. That's great. How many of you are students? 0. That's also a first. Oh, 1, 2. And how many of you are faculty or practitioners of some sort? Okay, so the majority is staff. That's very interesting, and I'm actually glad that that's the case. I'm going to talk about stress and burnout at an academic health center. And my default is going to be talking about physicians, but I'm not a physician. So for the staff folks in the room, this applies to everybody. There's some generic things. It just turns out that most of the work has been done in physicians. But the lessons apply to everybody. And the solutions are going to have to actually be generic if we're going to change the learning environment. I deal mostly with medical students and with our peers. But the time has come to really look at institutions across sectors completely. And so that's why I'm actually happy about the opportunity to speak to you today. I'm also going to talk, as you notice, about self-care, and I'm going to make the case that mindful practices are an important component of that. My day job is actually teaching about the kidney, and you might wonder, how does urine fit with mindfulness? I'm going to let you ponder that question. And then you're going to ask me, how'd you get interested in this? It wasn't through an epiphany. It wasn't through an epiphany. So let's start with some disclosures. The first is that much to my wife's chagrin, I don't have conflicts of interest. We have a child, our youngest is in dental school, where the tuition is $94,000 this year. Right, so I'm going to work till I'm 90. I'm not a mental health professional, but I will be talking about mental health issues. And so I want to put that in context. And when you will ask me a question about mental health, I would always defer to the professionals in the room. But I'm giving you a perspective as a physiologist and as an educator. That's what's bringing me to this. And I'm also a general skeptic, and yet I'm going to be talking about mind-body practices. And you wonder how that fits, and that's because I have an open mind. And much to my own surprise, as we began to implement some of the things I'm going to tell you about, I was very surprised by the reaction of students and faculty and staff to what we were implementing. It surprised me, and that's why I'm speaking about it, because I've become convinced that this is an important way in which you begin to change the learning environment. So here's what we're going to try to do in 45 minutes or so, is that I am going to talk about physician stress and burnout, and I want you to then to take those lessons and then apply it to your own situation, because you'll see many things that are in common. And then we'll try to explain why does this happen, even though the drivers for these things might be different. But there'll be a common theme, and the common theme is going to relate to the way we respond to stress. And that's universal. So once we understand that better, we'll be able to understand why certain interventions work, and then that'll lead me to telling you about our program at Georgetown that's been expanded to other schools. And finally end with what my closing comments are. So let's begin with a cartoon that might seem amusing. What seems to be the problem, Mrs. Johnson, and she says, I feel the way you look. He doesn't look very good, and you see this headline. And we kind of chuckle and go, yeah, I guess it's pretty bad, but actually it's not a laughing matter. It's serious. In fact, it's so serious that this paper came out in July, and if you're not aware of it, jot it down. It's free on the National Academy of Medicine's website. It used to be called the Institute of Medicine. Now it's the National Academy of Medicine. And this paper came out, and just to tell you who the authors are, so the leaders of the work that's been done on burnout have been at Mayo in Minnesota. Lottie Derby and Tate Chanafelt, who's now the Chief Wellness Officer of Stanford Healthcare. And you'll see that position actually become fairly popular. I imagine that every health center is going to name a chief wellness officer. That's how serious it's become. And it's going to be analogous to the quality issue when we began to name chief quality officers. And here's Colin West, who's part of that team and a good friend. But then the other authors, here's Christine Sinsky from the AMA, Pam Cipriano from the ANA, the American Nurses Association. Here's John J. Batt from the American Hospital Association, Alex Amaya from the AAMC, and David Myers from AHRQ. In other words, we've got a number of national organizations that have come together to say we have an issue here with burnout in the health professions. And it's worth reading this article. And for those that are going to have to leave, I'm going to tell you what my message is. That way you get your takeaway and you can leave right away. You don't like when I do this because it doesn't look good and it crowds this. Got it. So the take-home message is that physician stress and burnout, and let's extend that to all healthcare practitioner and staff, stress and burnout are widely prevalent. And in medical students, for example, it doesn't happen once they become physicians. It actually starts right in the first day of school. And it begins when what you see is reductions in empathy, and that leads to cynicism and impacts adversely on their well-being. And so my second bullet is that we have the responsibility as educators to do something about the learning environment. And so I'm going to advocate that we have to have curricular interventions. And for those that are not students, I'm going to say that we have to actually change the culture in our academic centers in order to change the way people thrive or improve the way they thrive in that center. And so that means that we have to help students and faculty and staff manage stress and foster empathy and build resilience. And it has to be part of the culture. And part of the culture does not mean, oh, we got a yoga class on the weekend or at 9 o'clock at night or at 6 o'clock in the morning. It has to be part of the culture. We have to live it. And it's hard. But I will tell you this. Every single institution I've been at, people go, yeah, we really need to change this culture. But somehow something's stopping us. So let's dive into what the issues are. So what is burnout? And Christina Maslach, the research psychologist at Berkeley, who in the 70s invented the term job burnout, describes burnout, first of all, it's job related. You could probably burn out at home, but it's probably because of the job that you're doing. But we're talking about burnout at work. And it manifests as a chronic response to chronic stressors, not acute. You don't get a horrible phone call, terrible news, and you're burnt out, but rather this is something that accumulates over time to the point that you just dread going to work. Now, how does it manifest? There are three characteristics. The first is emotional exhaustion. Emotional exhaustion. What does that mean? If you've raised teenagers, you know exactly what it means. Is that you give, and you give, and you give, and when you don't replenish, you find yourself empty, and at some point, there's nothing left in the tank. Emotional exhaustion. And again, for a healthcare professional, this is a problem. The second is cynicism and hostility that actually manifests as depersonalization. You'll hear that term as well. And this is where you're dealing with patients, or you're dealing with students, or you're dealing with colleagues, and they're no longer people, they're objects. And it initially starts as cynicism. And you see how the environment in the work setting changes from cynicism to hostility until it's toxic. And the third aspect that characterizes burnout, and people don't have to have all three, they could just have one of those. But the third one is what's known as a lack of personal accomplishment, or a sense of looking at one's profession, one's job for 30 years. And you look and you say, what have I actually done? Or is this all I'm ever going to contribute? And being that we're so perfectionists, we strive to achieve constantly, and we're very hard on ourselves, this becomes actually a real issue. Now, I will tell you that for physicians, this is not the major aspect of burnout, but it is in residents who are not quite sure yet, even though they've only been in it a few years. And it is in other job settings. The common theme that relates to the issue of healthcare is that when one manifests high levels in one of these three characteristics, it's also associated with an inability to express empathy, which is a problem. How bad is it? If you've read any of the studies from Mayo, this is the one that's citing the 2012 survey from Tate Shanafelt, you'll know that 1 out of 2 physicians, 50%. This is not a subset of individuals that aren't coping. This is widespread. And it's not just physicians, but it applies to all healthcare professionals. Nurses are burning out at a rate of 40%, and you can go down the line. It's just the most studies have been done in physicians. And it's across specialties. And some specialties, like the frontline ones, could reach 70, 75%. Even the ones that are the least, pediatricians, 35%. So 1/3. These are large numbers. And I want to show you just one piece of data from Mayo, because for me at least, when this came out 2 years ago, this really struck home that this is not a simply comes with the job, but rather there's a dynamic process here. So in this study, the physicians are in blue, and the general population is in brown. The upper panel is burnout rate, and the lower panel is how satisfied are you with your work-life balance. Now, you notice that in 2011, physicians were higher than the general population. And then over the next 3 years, what do you notice? The population has stayed about the same place. But what happened to the physician burnout rate? It actually got worse. Correct, it got worse. Now look at the bottom. How satisfied are you with the work-life balance? So the general population is over 50% pretty satisfied. And the physicians were lower, but look what happened. Over time, the general population shows actually an increase in satisfaction, whereas the physicians are showing a further decrease. In other words, the gap is getting wider. And for me, what this was is a recognition that we're dealing with a dynamic problem that's getting worse. And that is part of the issue, why all of a sudden organizations such as the AMA and such as the ACGME that oversees residents and the AAMC that oversees medical school are saying we have to do something, the time has come. Now, what's driving this, at least for physicians? And I have to tell you that for staff it will be different and for students it will be different, but at least for physicians, according to Colin West, he has at least 5 drivers that are there. The first is excessive workload. Now, I will tell you that working hard does not cause burnout. Working hard in an environment in which you don't control much, that causes burnout. Or working hard and not being appreciated, that causes burnout. So that's one. Increasingly higher expectations and decreasing resources. Inefficient work environment. For many, this is the electronic health record, as all those bugs are, everyone is dealing with those. Problems with work-life integration and balance. This is mostly about degrees of imbalance. Loss of autonomy and control. This isn't about the natives taking over the asylum. This is about how many people don't even control their own schedules. That somebody else controls their schedules. They don't even have that control. And that loss of control is really what is driving this. And then number 5, this is a really important element, is that the loss of meaning. Why am I doing what I'm doing? And you hear about physicians saying, I had to leave medicine because I couldn't practice the way I would wanted to or the way I was trained. Not sure why I do this. So those are the 5 drivers that at least he mentions, and there are others as well. Now in this slide, that was taken from a paper by Tate Shanafelt and John Noseworthy. John Noseworthy is the CEO of Mayo. And they wrote a very interesting paper called 9 Strategies that Organizations Can Begin to Adopt to Combat Burnout. And it's worth reading. Now what I like about this graphic is the left side describes some of the individual personal tolls, and the right side are the professional institutional tolls. And so you see how as burnout increases, yes, there are higher incidences of broken relationships. This is a big issue. Substance abuse, alcohol abuse, as people try to cope and are picking the wrong strategies to do so. And so for the AMA, it's about the impaired physician. For our colleagues, it's about the impaired physician. And yes, that does lead to depression. Not everyone who's burnt out is depressed, but the incidence does go higher. And then the suicide rate among physicians, I think you all know, over 400 a year. It's twice the national average. On the right side are the institutional tolls. And you see, yes, decreased quality of care, increased errors, decreased patient satisfaction, decreased productivity. And then here's the real dollar cost, which is the turnover. When a physician leaves, the estimates to replace that individual are huge to the institution. And that actually becomes the rationale that the finance people can begin to adopt, which is, wait, let's begin to implement a relatively low-cost intervention and try to save some relatively high cost that you will incur as people leave. Now, how do you begin to address this? And this is also taken from the Mayo paper that I just described. And what I like about this is that it divides the strategies into different buckets. So yes, there are some individual strategies, and that's really what I'm going to focus on in this particular talk. But I don't want you to leave here thinking that if you become the most mindful individual in your institution, that all will be well. Because if you're not in a healthy environment, it's just not going to work. It's going to help you a little bit, but it's the first step. So we begin with individual strategies, but let's recognize that you need to have work unit strategies because that's where you do most of your work. And there need to be institutional, organizational strategies because that sets the culture. And then there need to be national strategies, which is why the large organizations are involved. And all of these are part of the solution. There's not a single solution. But we are going to focus on individual in this talk. So, enough of the bad news. Now I'm going to give you the good news. The good news is we want to boost resilience. That's what we're after. We want to boost resilience. So what's resilience? Just out of curiosity, how many of you are mental health professionals, either psychologists or psychiatrists? Or just a few? Good. Good. So I actually could say what I want. You'll forgive me. All right, so here's the American Psychological Association defining resilience. Let's read this. Resilience is the process of adapting well in the face of adversity, trauma, tragedy, threats. Adapting well. I don't quite get adapting well. I don't know what adapting well means. And I say that because I found another definition that I actually like better. This one, by Epstein and Krasner. Resilience is the ability of an individual to respond to stress in a healthy, adaptive way, such as personal goals are achieved at minimal psychological and physical cost. Think about that. There are challenges. The key is, how do you cope at minimal physical and psychological cost? That's exactly what we want. Because our students that we're training Our residents that we're training, our faculty are all working in highly stressful conditions. That's not going away. What we want to do is give them the skills to be able to withstand that. So I like that definition, but I like part two even better. Resilient individuals not only bounce back rapidly after challenges, but also grow stronger in the process. There will be challenges. It will be difficult. And so the analogy is the tree in the wind. And as the wind blows and the tree bends, if you know anything about trees, you know that that actually strengthens the tree. And so the challenges that we face and bounce back from and grow from actually make us stronger, even better, even better. If you want a biological analogy, think about bone. What we know is when we put stress on bone, the bone actually gets stronger because we've changed bone formation. And that's really what we're talking about. So how do we foster resilience? How does it happen? And do you have to be unique? You have to be born with the right set of genes? Well, the person that studied this is Stephen Southwick, who is a psychiatrist at Yale. And his hypothesis, as he began his research, was, you know, there's something unique about highly resilient people. Let's find out what the secret sauce is. So he studied three populations of individuals. He studied former Vietnam POWs that survived the war and survived their incarceration and came back into society and became productive citizens. And the question is, what strategies did they employ to get through that? And they studied individuals that went through childhood trauma, physical abuse, sexual abuse, and again, became productive adults of society. What strategies did they employ? And then he studied special forces instructors. Again, in his mind, these are resilient individuals. And his conclusion is resilience is not limited to an elite few. Anybody can learn to become more resilient. Well, when I saw that, we invited him to speak at the first Centile conference in 2015. Because that's an important message. If we can teach people to become more resilient, then how do we do that? Let's get on it. So you want to know, right? Well, you got to buy his book. Here's his book. It's $10 on Amazon. The Science of Resilience. Okay, so here are 10 things that he's described. And I'm going to go down this list very quickly, not to delve into each one, but what I want to say is that there's probably nothing new here. You probably already do this automatically. So here's his 10 things. Bringing positive emotions to bear as opposed to negative emotions. Regulating your own emotions, emotional intelligence. Coping style. Are you the kind of person that gets engaged, or are you one that passively, aggressively is just complaining? Social support. We all recognize the power that has. And then something new, cognitive flexibility. That's a new term, cognitive flexibility, or sometimes called cognitive reappraisal. And I wondered, what is that exactly? And then as I began to practice some of these techniques, I began to understand. How did I know? Here's an example. So Cleveland used to be a hub for United. I think it's still a sore point for some of you. I know, because I used to come through here a lot. Well, now we go through Chicago, and we hate life, right? Yeah. So someday, about 2 Octobers ago, you might remember this, I was flying from Nashville back to DC, middle of the week, and I had to make a connection in O'Hare. And I get on in Nashville, and everything is great. And I get to O'Hare, and everything is wonderful. The sun is shining. It's a beautiful day. I get off the plane, and there's bedlam at O'Hare. Bedlam. And you go, what's going on? And people are screaming. It's like chaos. So you take out your phone, and you know, look at CNN. What's going on? Well, it turns out that United's computer systems shut down that day in October. Some of you may have been on the road that day. And so it's like, oh my God, we're stuck, it's over. I'm walking to my gate, people are screaming, you know, you get the folks that come in your face, I hate this airline, I'm never flying this airline. And I come to the gate and I just noticed there's the plane, there's the pilot, the crew is here, sun's shining. It's not so bad. No international connection, right? I mean, these are the kinds of things that go through my mind. And so I took out the phone, go on Facebook, because I like to irritate my kids. And I just copy the headline, and I go, you know, stuck in Chicago, computer systems down, but the plane's here, the sun's shining, and the pilot and crew are at the gate. Thank God for cognitive reappraisal. That's what I wrote. I was thinking about this slide. And 30 seconds later, my daughter writes, typical. But I have to tell you, until I actually learned that strategy, I probably would have been just like everybody else, agitated, screaming, and for what? You know, you just frame it in a different way and things begin to change. So, resilience. Well, here's the definition that I alluded to earlier from Krasner and Epstein on physician resilience. It was an editorial in response to a very interesting article in Academic Medicine in that issue, which it was a German study that said, if 20% of German physicians are burnt out, what about the other 4/5? What are they doing? It was very interesting, and it was a litany of what are people doing that actually aren't burnt out in Germany. And so they wrote this article, and here's what they listed. Individual factors of resilience. And you notice they have self-monitoring, setting limits, attitudes that promote constructive engagement, everything that we saw, some of the things that we saw Steve Southwick write. But then, what's the first thing they wrote? Capacity for mindfulness. What? Where does that fit? How did mindfulness get into the equation? So, time for an experiment. I've been talking for 25 minutes, and I'm a physiologist, so we're going to try something. Here we go. You ready? Well, you don't really have a choice, but humor me. Here's what I want you to do. I'd like everybody, we're going to do a very simple exercise. I'm going to invite you to go to a place in your mind that's very familiar to you. So what I'd like you to do is just sit comfortably, and just for 3 minutes, put both feet on the floor. Go ahead, just do it for me. Sit up straight, put your hands wherever they're comfortable, and let's just do something very simple. We're going to call this breathing. Let's just take in a breath and slowly exhale. And you might try to see if you could breathe in through your nose if you're not stuffed, and exhale through pursed lips, because then you could extend your exhalation. Just try it one more time. Breathe in and slowly exhale. And let's take 3 of these breaths. And on the second breath, just let your shoulders drop so that you're actually allowing yourself to enjoy this moment, even though you're at work and we're sitting in a conference center in an auditorium. Let's go one more time. Just breathe in and slowly exhale. And you might find it easier to just close your eyes so you're not distracted, or you can fix your gaze in front of you if you prefer that. And let me invite you to imagine that you're standing in your kitchen. And just take a moment to look around this very familiar place. Notice the cabinets. Notice the color of the appliances. And notice that everything is spotless and put away. The kitchen looks wonderful. And take a few moments to see if you could detect any sounds in the kitchen. Perhaps the hum of the refrigerator. Or maybe something delicious is cooking in the oven. So there's a smell that's drawing your attention. Maybe the dishwasher is running. Now walk over to the counter where you notice a cutting board and a knife, and on the cutting board is a ripe, plump, juicy lemon. And walk over and imagine picking up the lemon and feeling its weight in your hand and its texture. And you feel it, and you realize this is a very juicy lemon. And with the knife, go ahead and cut the lemon in half. And feel the resistance to the knife as the lemon splits. And some juice might have spurted on the cutting board because it's a very juicy lemon. And notice the pale yellow of the pulp and the whiteness of the inner peel. And then go ahead and take one of the halves and cut it with the knife again in half. And so now you have 2 quarters. And you might have cut through a seed or 2. And more juice might have spurted on the cutting board. And pick up one of the wedges and bring it to your nose and see if you could detect the sharp scent of this fresh fruit. And now imagine taking the wedge, putting it in your mouth, and taking a bite out of this sour, fresh lemon. And just hold that sensation. And when you're done, put down the wedge, step away from the counter, take a nice deep breath, and come back and join us in this room. Come back. And when you come back, if you wouldn't mind looking at me so I know you're here and we don't have to go find you. Let me just make sure everybody's back. Right, very short, quick exercise. Everybody back? I think so. Anybody have any trouble imagining the kitchen? How many were shocked that it was spotless? That was a new addition. 2 months ago I did it and a woman said, as soon as you said kitchen, I got all stressed out. I said, you know what? I'm going to change it. It's spotless. Can you imagine the lemon? How many can you actually smell it when you brought it to your nose? Just by a show of hands, how many could smell it? And then when you took a bite, how many could taste it? Even more. Anything else happen to you as you're imagining this? What happened, Amy? You started salivating? You started salivating? How many of you started salivating? Yeah, look around the room. Yeah, and the rest of you are actually ignoring me. So here's a bit of sobering news. There's no lemon. There's no lemon in this room. Did it matter to your physiology? No. Here's what happened. The neuroscientists back me up. Here's what happened. As soon as I said lemon, bingo, hippocampus. I know what a lemon is. I know what a lemon is. And then the amygdala is attached to the hippocampus. I love lemons. I hate lemons. Some of you made faces as soon as I bite into the lemon. You're making a face. It's like crazy. There's nothing in the room. But it didn't matter. Why did most of you begin to salivate? Because the brain knows. You're going to eat something with a pH less than 2, and we better get ready for it. And whether you actually bit into it or you imagine biting into it, it didn't matter. The wiring is there. And so my point in doing this exercise with you is I could say the word mind, body all day, and you'll think I'm someone from San Francisco. But the fact is that the mind and the body are connected. It's a wiring. It's in us all the time. And now the question is, what do we do with this? Is this a trick? You're going to go back to your offices after this hour. Someone said, you went to that hour? What'd you do? Say, oh, close your eyes. And you're going to do this little exercise. Or is there something that we can utilize to actually help us? And so how does this relate to mindfulness? Which turns out to be one of the issues for resilience. And how does it impact on stress and burnout? I mean, let's connect the dots here. So let's take a definition of mindfulness. So here's John Kabat-Zinn. If you don't know who he was a molecular immunologist at University of Massachusetts. And in the 70s was also involved with Buddhist practices and brought the Buddhist approach of mindful practice to the University of Massachusetts as a way to help patients with chronic pain learn to manage their pain. Way ahead of his time. So he secularized this practice of mindfulness. Now, here's how he defines mindfulness. And I bolded the words that I think are the key ones that I'd like to focus on. The first thing is this: mindfulness is an awareness. What does that mean? It's not nirvana. It's not the end goal. It is something that you begin to notice. So how does that happen? You begin to pay attention, very specifically. So on purpose, you're paying attention on what? On the present moment. Now let me stop right there. You're paying attention purposefully on the present moment. Now let's be honest with ourselves. You came to hear this talk, you made the effort, you're coming here, you're sitting down, you're listening to me. But I would venture to say that in the last 35 minutes, you've had lots of thoughts running through your mind. You've been thinking about emails, you're thinking about people you got to talk to, you've been thinking about what you can cook for dinner, you've been thinking about the fight you had last night, you're thinking about if your kid is actually doing okay. I mean, you've had all these thoughts in your mind, and yet you came here to listen, because what happens is this: we spend most of our time thinking about what we're going to have to do or what we didn't do. We're in the past or in the future. But are we in the moment? Hardly ever. We don't give ourselves permission to be in the moment. We're always planning, we're always doing. We're not in the moment. So, mindfulness is simply notice the moment. Then come the next two words, which are the hardest ones of all: without judgment. So I tell you, let's take a moment and focus on the present without judgment, right? So you're going to focus on the present, and you're going to say to yourself, I really suck at this. You know, I can't, because I got thoughts in my head. I really can't do this right. Because you're judging. Without judgment means I'm not noticing the present how I'd like to be. I'm not saying I like what I'm doing, I don't like what I'm doing. I'm just noticing what it is. Good or bad, like or not like, doesn't matter. What is it right this moment? It's one of the hardest things we do because we judge all the time. We aim for perfection. I bring a group of medical students in the room. We're going to practice mindfulness. And I know that in their minds, they're saying, I'm going to be the most mindful one in the class. This is just the way they're wired. And you say, no, there's no best or worst. There's just what is for you. Now, I'm saying it, and you're thinking, really? That's so easy. How did he learn to do that? Well, let me tell you, this is the hardest thing of what I'm going to tell you all day. You see, I was born in Jerusalem, and I grew up in New York. We do judgment for breakfast. You know, we finish your sentences because we're so sure we know what you're going to say. We don't have the patience to wait for you to say it. So when you suspend judgment, it's actually very powerful, but it's hard to do. But that's the first step, is you notice what happens. So why am I telling you this? I'm telling you this because this is the first step in actually becoming aware of your own emotions and your own self. And so when we talk about mindful, here's an adult and a child walking in the park. And you know this, the child is totally in the moment, and the adult is full of stuff. So is it mindful or is it mindful? Which way is it going to be for you? Now, the reason I'm telling you about mindfulness is because of this paper. So if you haven't seen, how many have not seen this paper? Be honest. Good. That's why I'm telling you about it. It's great. So this was a paper that appeared in JAMA in September of '09, and notice with me, Association of an Educational Program in Mindful Communication with Burnout, Empathy, and Attitudes Among Primary Care Physicians. Here's what happened. Rochester, New York. Survey goes out to primary care practitioners in the community, and mostly to assess their burnout scores. Individuals that scored high were invited to come to the University of Rochester site and to participate in an 8-week program, Wednesday nights for 8 weeks. I'm going to tell you what they did in those 2.5 hours. And then after that, it was once a month for the rest of the year, and then they followed them for 3 more months. So there's the intervention. Here's the intervention. Wednesday night for 8 weeks, all day Saturday, and then once a month for the rest of the year. And then they followed them. Now, what did they do for the 2.5 hours? Here's one, 15-minute didactic part on stress, on burnout, on becoming self-aware. 15 minutes. I've already spoken 38, so you could see it's a very short component. And then they did one of 2 exercises. This is the interesting part. They did one of 4 mindfulness meditations, and if you're wondering what these are, if you're not familiar with it, body scan, sitting meditation, walking, this is all about body awareness, becoming aware of yourself. Appreciative inquiry is a writing exercise. And this is the one where you focus on what brings meaning to the work that you do. You appreciate your strengths. You try to scale that up. How do I do more of what brings meaning to the work that I do? So this is about meaning, and this is about awareness. And here's what they found. I'm kind of cutting this short without showing you numbers. They found that the group had sustained levels of reductions in burnout, sustained levels of an increase in empathy, and an increase in mindfulness. And the higher the mindfulness, these are two scales for each one of these. The higher the mindfulness, the bigger the changes in empathy and burnout. Amazing. It was amazing that JAMA published it. So we come to the first conclusion. And the first conclusion is what? That although rates of chronic stress and burnout among primary care professionals are high, it turns out that if you practice mindfulness, you can reduce burnout. Okay, interesting. But now let's put on our scientific hat and say, well, why would that work? What is it about mindfulness? I mean, it's not just this magic pixie dust from Disney. Why is mindfulness doing that? So for that, we need a hypothesis. So here's the hypothesis. Every day we are beset with stressors. Every day. And the way we respond to stressors, appropriately or not, will determine whether we will head towards burnout if our response is impaired, or if we begin to employ strategies to help us manage stressors better, we can actually reduce that burnout and actually boost resilience. That's the hypothesis. So it comes down to how do we respond to stressors. So here's a quick physiology. Return to physiology. How do we respond to stress? I know you all know this, but humor me. That is a stressor, this cloud hanging over us. Now, it turns out that it doesn't matter if it's physical stress, emotional stress, psychological stress. I'm breaking up now with a very long-standing relationship, or I'm actually in physical pain, or my kids are torturing me, or pick your favorite. I'm walking in a neighborhood of a place I don't know, and all of a sudden I'm getting a little anxious here. Whatever the stressor is, the brain will appraise and make a decision. Is this a threat or not? And if the decision is yes, this is a threat, then the cascade is exactly the same. And it begins with the hypothalamus releasing a peptide called CRH. And then the pituitary responds and releases ACTH. And then ACTH travels through the adrenal gland and releases something you all know, cortisol. Cortisol does a lot of things, but one of them is raise blood sugar. It's a glucocorticoid. Meanwhile, CRH in the brain actually stimulates the sympathetic nervous system. So heart rate goes up, blood pressure goes up, blood flow to muscles goes up. And coupled with the rise in glucose, you now have a perfect matching. You have the fuel to enable you to deal with the threat. Is this a good thing or a bad thing? This is great. This is how we survive in the jobs that we have. In fact, this is so good that look what happens. Here's cortisol. Well, cortisol feeds back to the pituitary to shut off ACTH. And ACTH feeds back to the hypothalamus to shut off CRH. And CRH in the brain could turn itself off. And so now we have a perfect system. This is actually fantastic. So we have a perfect system. We have a stressor. Our stress hormone goes up. We deal with the threat. Stress hormone comes back down. And everything is great in the world. So why are we talking about stress as if it's bad? What's our problem? What's going on? Sustained stress? Probably. How about something very obvious? Let me ask it this way. How many of you deal with one stressor at a time? Exactly. Now watch what happens when you get one on top of the other. What do you notice? What do you notice? This didn't come back down, did it? So now you're going to hit a stressor at this point, and guess what happens? Oops. Now what happens? Now, do I need to give you a scenario of one stressor on top of the other? I mean, I live in DC, right? So we have the Beltway. You got your own issues. I got my issues. I know that a certain place in the Beltway, the traffic is going to be backed up. I am prepared for it. But one day I'm going to outsmart this, and I'm going to get on a different entrance point. And I do, only to find that traffic is completely stopped because a tanker flipped. And I could feel that tightening in my chest. I didn't expect that. Then the phone rings, and my chairman wants to know, why am I running late? I'm supposed to chair this meeting, and that tightens a little bit more. And then the phone call rings, and my son tells me, I'm sorry, I dinged the car last night. And that just about did it. Right? We do this all the time. So the whole point of what I'm going to tell you is this. Watch this slide. This is what we're trying to achieve, is bring the levels back to baseline. Now, the consequence of not bringing the levels back to baseline is this. The first thing is that the high cortisol impairs the feedback system. So that beautiful system that you saw doesn't exist anymore. It's now dysregulated. So now you're impaired. Think about this. I ask you to run up 3 flights of stairs. You go, okay, I can run up 3 flights of stairs. I ask you to do that after you haven't slept all night. Not so easy. That's what happens when you're impaired and you're not dealing with the stressor adequately. We're impaired, and it has a consequence. So chronic stress compared to acute stress, very big difference. So here's something very interesting. You take hippocampal cells. That's the part of the brain that we learn in. You look at the 2 neurons, and you're measuring synaptic transmission between the 2 neurons. How well do they function? Now, it turns out if you put a little cortisol in, the synaptic transmission is optimized. It's better. But if you put a high-dose cortisol, it blunts it. Now, what's the lesson for us? Think about your own situation. You have to perform a procedure, or you have to stand up and speak to people, or you've got a big deadline coming up, or you got a big test, and you can feel this thing in you, and you're nervous, right? You're nervous. But your mind is sharp, because a little cortisol is actually helping your mind. But you do that when the cortisol level is high, and now you can't read, you can't think, you can't study. Right, so there's actually brain correlates to what we're talking about. So differentiate chronic stress, which is bad and makes you sick, with acute stress, which is actually helps us function better. So what's going to help us get back to baseline? Right? That whole point was to get us back to baseline. What's going to do that for us? Well, this is where mind-body medicine comes in. This is why it's effective. And so if we're talking about meditation, or if we're talking about guided imagery, or if we're talking about, you name it, autogenic training, we're going to have a self-hypnosis. So if we're talking about just breathing. Now ask yourself honestly, we just took a few minutes ago, did a breath exercise. We took 3 breaths. Did you ever do that at work? Like just close the door and just take 30 seconds to just breathe and actually just center yourself again. If you do that regularly, then you're very astute. Most of us don't give ourselves permission to do that because we're too busy. You know, we don't have time to take 30 seconds. But that actually will give you a new baseline. Now, for some, it's exercise. If I don't exercise, I'm not normal. And then for others, it's a little softer, yoga, tai chi. And then group support is something that I include in this as well, because groups are healing presence. And when we work with colleagues in a group and do things together, we actually do better. So the question is, so why does mindfulness meditation actually help us respond to stressors? What are we doing? We're focusing our attention without judgment on the present moment. Well, here's what's happening. When we focus on that present moment without judgment, just what's happening right now for 5 seconds, our levels begin to come down. That lasts 5 seconds, and then boom, a thought comes in, and then you're up again. So the trick is to practice. Can I extend that to 10? Can I extend my focus to 15 seconds, to 20, to 30 seconds? Can I extend it to a minute? And that takes practice. This is why we call it practice. It's not easy, but that's the whole rationale. Now, when you begin to practice mindfulness meditation, look at some of the physiologic benefits. Blood pressure goes down, heart rate goes down, cortisol goes down, sympathetic arousal goes down. Again, it's not magic. You're just running the stress response in reverse. And not just physiologically, but psychologically. Think about it. You feel less stress. You feel less anxious. People report, I'm not ruminating as much when I do this regularly because I'm able to center myself. So it's the psychology of de-stress. So that, when we look at Colin West, here are his 5 drivers. Let's go back to him. And what he does on this table, I borrowed this slide from him. Here are individual interventions, here are organizational ones. And as I said to you, they're going to be solutions in multiple parameters. So, you know, for the workload, yes, you're going to have to change the productivity targets, or basically people aren't going to survive. But under the individual, look how many times the word mindfulness appears as a strategy for individuals to cope better. And here's a report. They did a systematic review published last year in The Lancet on interventions to prevent and reduce physician burnout. Here's the conclusion. The most commonly studied interventions involve mindfulness, stress management, and small group discussions. And there's a reason why I'm showing you these 3 things. Because these 3 things are going to be elements of an intervention that I'm going to describe. So we come to conclusion 2. And with this beautiful child with perfectly formed fingers, here's what we learned. That it turns out that when you practice mindfulness, that mind-body connection that we know exists because you've experienced it actually helps us de-stress ourselves, but also creates a new baseline for us. And I call this our reboot, our personal reboot. Now, what do you do with your phone when it's frozen? Or your computer when it's frozen? I know, you're IT geniuses. What do? You shut it off and you turn it on again, right? Right, we all know how to do that. Right, and then everybody says, you're a genius. That's what we need to do to ourselves on a regular basis. Now, does it take 2 weeks in Tibet to get us there? No, we can do it in 30 seconds if we practice to just pause, Now, for each of these talks in the last year, I've been pulling out an article from a different specialty to say, let me just show you what came out. So this is March of 2017. Here's a paper, Pediatric Resident Burnout and Attitude Towards Patients. So this is from 11 residency programs, 53% response rate from 258 residents, 39% of their pediatric residents were burnt out, and that was associated with greater odds of reporting suboptimal patient care. It's prevalent everywhere. I pick pediatrics because they're actually the most protected. And you see what happens. And that led to an editorial from John Mahan, who's at Ohio State down the road. And what does he say? A call to action. And so the pediatricians have formed something called the Pediatric Resident Burnout Resilience Consortium to begin to address this. And they're not the only ones. This is moving everywhere. Now, for those that deal with medical students, this is the most disturbing paper that I read in the last 10 years. And I'm going to tell you why. Distress among matriculating medical students relative to the general population. This is 6 medical schools. Looked at the mental health parameters of incoming medical students. And guess what? Medical students begin medical school with better mental health indicators than age-matched college graduates. Our students come in pretty healthy. And guess what? Within 1 year, that changes and never comes back. And so the conclusion is that the learning environment and training process contribute to the deterioration of mental health in medical students. Think about that as I'm looking at our Associate Dean of Curriculum. To me, this is a stinging indictment that something has to change in our schools. People are coming to our schools, they're smart, they're excited, they're motivated, and the training process is creating toxicity. They're getting sick. And yet, look at our mission statements. None of them say we're going to make our kids sick. No, we're going to train healthy, we're going to train knowledgeable, skillful, compassionate people, because we all mean well. But somehow the system is rigged wrong, and we have to do something about it. And we know what happens. Here's empathy from the University of Arkansas. Bruce Newton did a very courageous study. He followed the same class through 4 years of school and watched empathy erode in both males and females. And the differences in the curves were the surgeons are the lower line of each, and the anesthesiologists. The pediatricians and the family docs are in the upper curve. But they go down everywhere. And they go down right in the first year. So this isn't just a clinical problem, I tell my basic science colleagues. And there's a consequence. Empathy decline will actually threaten healthcare quality. And then in this one, 7 medical schools participated in this. 52% of the students had elements of burnout, and those students were more likely to engage in an unprofessional act. There's consequences to what's happening in the schools. And yet, if you look at curricula, what you see is, yes, we're going to teach them to be communicators and have good clinical skills and so on. And look at number 6, self-awareness and self-care. We have it up there. This happens to be from Brown. And not to call out Brown, I show this because they were the first school to move to a competency-based curriculum. But when I asked the Brown dean, tell me, how do you achieve this? His response to me with a straight face was, we give a really good lecture in the first year on the importance of eating right, getting enough sleep, and taking care of yourself. A lecture in the first year. To which my response was, I am sure it is very effective. So this was a long-winded way to get you to this point, which is 15 years ago we began a program in which we introduced mind-body medicine by hiring Nancy, who was a mind-body expert, to create a course for us that would foster self-awareness and self-care for students. This is 7 years before the data came out on medical student burnout. And we did this at the time. Now it seems like we were prophets, but at the time, it was because the big issue in medical schools back then was communication. Our students didn't know how to communicate with patients. So we needed a way for them to communicate. Well, the first way is understand yourself, then you can communicate with someone else. And so the program functions basically, it's a volunteer group. It's not for everybody, the way this is constructed. And we could talk about why. But we take 10 students and 2 faculty facilitators that we have trained. And we call it 11 weeks of self-discovery. Now, there's certain parameters. These groups are confidential. They're based on mutual respect, compassionate listening, and non-judgment. It's the only part of non-judgment in medical school. It's not for every faculty. It's not for every student. But what we do is we get together, and we just listen to each other. We're not fixing. There's no therapy, but it's therapeutic. And we spend the first hour checking in, just going around the room. How are you doing? What's going on in your life? The first week, it's pretty superficial. The third week, it gets a little deeper. The 7th week, the group has really bonded. And that's part of what's effective about it. And then we introduce a new skill, and we process. What was that like? What are you learning about yourself? And the skills are designed, and here they are, to basically allow students to reflect on how they're responding and what is coming up for them. So this isn't about just learning to meditate. It's about learning about yourself. The self-awareness component is the key. And so yes, we use art and we use music and we use movement and we do writing exercises, and it's all wrapped in group support. And this is what it looks like. So you have a group doing an opening meditation, and this candle is not a religious object. It's designed to start and end the group, but also to be a focal point, to allow people to focus on the present. And here they're doing one of the drawing exercises, which is a non-cognitive drawing exercise. You basically allow things to happen on the page without constructing it rationally. And our outcomes, again, I don't have time to delve into all of this, but stress goes down, mindfulness goes up, empathy goes up. It's all linked to the change in mindfulness. And so 10 years ago, we wrote the first paper on what the students report. And they report that they feel connected now with students, and they begin to discover things about themselves, and they're learning more aspects about themselves. And it's not just about faculty. I mean about students. It's also about faculty. And that's what I want to tell you. And it's also about staff. We have these groups going on for the staff. So these happen to be facilitators. But we also bring them together for their own self-care. And then 2 years ago, published this article as we began to ask our facilitators, tell us, what is it like to be a facilitator? What's it doing for you? And so here what it did is it reaffirmed their own professional identity. So what we found in this is 62 facilitators. Half were at Georgetown, half were outside of Georgetown. And we found improvements in communication between colleagues, an increased sense of connection, increased empathy. They felt better about their new role. And I would extend that to doing this with staff as well. This is a new role that people have. And so over the 15 years, we've trained lots of people. In our medical school, in our law school, business, foreign service schools. Yes, it's expanded. This is one way that you achieve this competency at our school. But what it's also done in this article that the AAMC put out in 2008, here's the title, The Mind-Body Skills Course is Changing the Culture of Medical Education. If you remember when I started this, I said this isn't about a yoga class on a weekend. This is about changing culture. For our school, this has begun to change the culture. I will tell you that only 40% of the class, that's a big number. It's 80 students out of 200. But 40% will take it. The majority don't take it, and you might ask why. That's an issue because it's not for everybody, which means we need other offerings. But for a large component, this actually made a big difference. So we begun to offer trainings about 8 years ago to other schools. It's a 3.5-day immersion where you live the course. And then we give you all the materials to start it. And so here are the schools that have begun to move. And in Cincinnati, they're doing this across the entire university, and in other medical schools, and in other places in Europe. So this program has expanded with more and more data coming out. But I don't want to just do this didactically and just tell you. I want us to experience something. So let's take a moment. This exercise will take 3 minutes. So for those that need to leave at 1, I promise you 3 minutes. But here's what I'd like you to do. Is just sit comfortably, both feet on the floor. Just take a moment, put away your phones. I know it's hard, but just go ahead. Actually, you've been great. And let's just take a moment and just notice, if you will, what are you feeling right at this moment as I begin this? So as you find a comfortable position, with your neck and your spine aligned and comfortable, closing your eyes if you wish, or just fixing your gaze in front of you. And let's begin this exercise by simply starting to notice what is here for you right now. So maybe asking yourself, what's my experience right now? Noticing any thoughts, noticing any emotions that you're having. Not trying to change anything or trying to get anywhere. Just noticing and taking an inventory. And you may even tell yourself, whatever my experience is, it's already here, so let me just feel it. And now let me invite you to gather your attention and notice your breath. Focusing all of your attention on your breathing. Notice the air going in and out of the nostrils and your nose. Notice your abdomen moving up and down as you breathe. Just taking a moment to feel the breath. And as your mind wanders off, just gently bringing your attention back. Back to your breathing as best you can. Now expanding your attention to becoming aware of your entire body. So perhaps as you breathe in, visualizing the air filling your body, moving from your head down to your chest, to your abdomen, all the way down to your toes. Sense your entire presence and being in this moment. And when you're ready, slowly and gently bringing your awareness back to the room, back to the present. And at your own pace, opening your eyes slowly. And as you slowly come back into the room, notice what you're feeling. Notice how you are, alert, awake, calm, relaxed. Whatever you're feeling, that's what's happening to you right now. That was 3 minutes. Do you feel any different? You just took a pause. It's not hard. We just don't do it. It turns out we're the biggest barriers to just allowing ourselves to be for a few minutes. So let me close as you reflect on that experience, but just sharing with you just a little bit. Some of the schools that began to implement this program. Here's one from Charité, Germany in Berlin, making better doctors using this skills course as a self-care element. Here's a paper from the Netherlands and Sweden together in medicine and nursing students. And participating in the medical nursing students showed significantly increased empathy and decreased personal distress up to a year after taking the course. This is a long-term effect. And then this paper came out from our school in September online. It's coming out in print next month. This was where we followed up graduates of our medical school for those that actually participated. What are they doing now in residency? And it turns out the preliminary evidence suggests that mind-body training during medical school has long-term positive impact on physicians during residency in terms of their self-care and how they approach patient care. There are long-term effects. And that's why the AAMC is interested. This is their wellness page. The ACGME has a physician well-being page with lots of resources. And the two got together with the National Academy of Medicine to create this action collaborative on clinician well-being. This is on everybody's agenda. This is less than a year old. They started last January. And they're going to issue a major report in the next 12 months. So as we think about healthcare and we think about the triple aim that Don Warwick espouses of patient, better health, and better patient experience at a lower cost, Bodenheimer and Sinsky said, wait a minute here. there's really a quadruple aim. You can't do this without care of the provider. And that means each one of us. We have to take care of ourselves. So here's my summary for you. What have we learned? What have I tried to tell you? Well, I discussed physician stress and burnout. I extended it to, I hope, all of us in the academic health center and said that it's a serious issue. That mind-body medicine is not magic, but it's simply the physiologic interface between mind and body. And if we use it in the reverse direction of the stress response, we can de-stress. And it turns out if you do that by employing mindful practice and enhancing self-awareness and remembering why we do what we do, then this could begin to reverse the changes that we see. And that we have to do this not only in our curriculum, but also in our culture. So what do we do tomorrow? What do we do tomorrow? The educators in the room, this is your turn to step up and to get involved. If you haven't already done so, I suggest having a faculty-student, faculty-student task force. Assess what is the status at your institution. If you haven't done it already, do it. If you've done it already and you have no problem, publish it. You're the only institution in the world. It's more likely that you'll find that there's a problem and that there should be a collaborative effort to implement. My point is that the status quo is unacceptable. You can't just watch this train wreck in slow motion. We have to do things. Now, I talked today about mind-body medicine, but I want to be clear, that's just one approach. There are many, many other things that one can do. This is just one, but it's one that I actually believe in. It's important that people not feel marginalized, so it's one of these, oh, you better go to this thing, is not going to be an effective way. But I encourage you to develop programs, to report on them, to disseminate them. Ultimately, it's going to take courage, and that's where leadership steps in. My final thought is this. You saw how I led that group? You saw how I led that exercise? The first time I did that, 15 years ago, I thought I was going to lose my mind. I was sitting with a group of 10 students, and I had the bells, and I rang the bells, and I was reading the script, and the whole time I'm going, this is insane. This is not my words. I have no idea what I'm doing. This is crazy. And I had images of my thesis professor looking down from the heavens going, this is what I trained you to do? And yet that moment passed because the students were riveted and they didn't see my discomfort. What they saw was, wait a minute here. My professor is taking time in the evening to lead this group. They care about me. I ought to take this seriously. And so that's when you realize that if you want to change an institution, you have to get out of your comfort zone and lead. And that's why I came to give this talk. And I encourage you to do the same. You have fabulous people here. You care about your staff. You care about your colleagues. You care about your learners. Let's do it. I wish you luck. Thank you.